Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to be talking all about Morton's neuroma and metatarsalgia, two technically different conditions, but they can present very similarly. They develop for very similar reasons, and actually the treatment is not that dissimilar for both of these conditions. So let's get into it right now by beginning with talking about Morton's neuroma. A Morton's neuroma is also called an interdigital neuroma. Here's why. If we look on the leftmost side of the screen here, you see a plantar or bottom view of a person's foot. And there's some nerves there emerging from the medial side of the ankle. And as the nerves go out towards the foot, they divide into different branches, and some of those branches wind up in between the rays, or we could say in between the toes, and that's potentially where a neuroma forms. In fact, if you look here, circled in blue, there's a thickening of one of those nerve bundles between the third and the fourth ray, and that in this case is the neuroma. And if I was being very specific, I would call it a 3-4 interdigital neuroma, or Morton's neuroma. Now, what causes a Morton's neuroma to form in the first place? Well, there's a plethora of potential impairments in the foot and ankle, and sometimes going up as far as the hip joint, that can contribute to the formation of this condition. To really figure out what's going on in your specific case or that of someone that you know and care about, that person should be checked out by a qualified physical therapist to determine the exact source of the issue. However, what I can tell you is at the top there, one of the most common impairments that we see in a lot of individuals and can certainly contribute to this neuroma forming is limited dorsiflexion range of motion, limited dorsiflexion mobility at the ankle. So when you are walking, let's say I'm talking about my right foot because I did have a neuroma on that side. When I'm walking and I'm swinging my left leg forward, so my left foot's in the air, but my right foot is still planted on the ground, what's happening at that right ankle? Well, let's say this right here, this is my right foot. Let's say this is my right ankle joint, and right here, this is my right tibia. Well, of course, as my left leg swings forward, my right leg, or ankle I should say, has to dorsiflex. And it should dorsiflex fairly smoothly as I go into pre-swing, right? As I start to go up onto the toes, but before that happens, I need to have a smooth transition into dorsiflexion, which would occur in that terminal stance phase of gait. But what happens if that dorsiflexion is limited? Well, you gotta move, right? You gotta be able to walk. So rather than having a smooth transition into that dorsiflexion and essentially the force and energy being dissipated, it can't do that because it's stiff for one reason or another. So you get a ton of force absorbed into the forefoot. Okay? And since we're usually moving around walking all day, you get a repetitive increased pressure through the forefoot. And in the case of a Morton's neuroma, it puts repetitive stress on that nerve bundle, in this case between the third and the fourth metatarsals. Okay? And when you get repetitive stress on the nerve bundle, a protective fibrosis forms around the nerve bundle. Now, the protective fibrosis is supposed to be protective to protect the integrity of the nerve. The problem is this resulting neuroma causes a lot of pain. Now, in the case of a Morton's neuroma, the pain is not on the metatarsal, it's not under the metatarsal, it is between the metatarsals. And as opposed to metatarsalgia, which we're going to see in just a minute, a Morton's neuroma is a focal point of pain. It's like one little spot, like you're stepping repetitively on a small pebble or a very small marble. It's not this diffuse area of pain on the balls of the foot that you can brush with your fingers, right? Just one singular point of pain between the metatarsals, and it may have numbness and tingling. It may have an audible click. Some sources online say you have to have these for it to be present. That is not true. You can have a Morton's neuroma that does not have a click. You can have a Morton's neuroma that has neither numbness nor tingling, okay? But they can be present. And there's also going to be a positive Mulder's test, which I'm going to demonstrate right now. To perform Mulder's test, the textbook method would be to grip the patient's foot on either side at about the level of the MTP joints. Index fingers on the bottom, thumbs on the top, so a lateral prehensile grip from each hand, and we're going to gently and slowly try to compress the metatarsals together and assess for a pain response. Now, if you know that the person's pain is highly irritable, highly severe,
The recommended way would be to start a little bit down proximally. Again, being very slow and gently work your way up, assessing for that pain response. And technically, a positive Mulder's test, which would be a Mulder's sign, would be reproduction of the patient's familiar pain. And note that there could also be numbness or tingling that's reproduced if it's a Morton's neuroma, and also audible clicking if it's a Morton's neuroma. Understand, though, that reproduction of clicking and or numbness tingling would not necessarily be a positive test if there was no pain that's reproduced. Pain is the kicker, and that is their familiar pain, with or without numbness and tingling, and with or without clicking.
Now, switching gears to metatarsalgia, and we're going to skip to the bottom of the PowerPoint slide here to differentiate this from a Morton's neuroma. So whereas a Morton's neuroma had that pain situated between the metatarsals in the intermetatarsal space, or interdigital space, the pain here is actually on the metatarsal, specifically the distal metatarsal, right around the MTP joints. So when that foot is going into pre-swing, where your heel comes up off and the balls of the foot are where the weight-bearing source is, that is where the pain is going to be present, but on the metatarsals, not between them. Also, for metatarsalgia, there is never numbness and tingling. Now, absence of numbness and tingling doesn't mean it is metatarsalgia. It could be a Morton's neuroma. But if there is numbness and tingling, it can't be metatarsalgia, okay? Unless the numbness and tingling is coming from some other condition like a lumbar radiculopathy, okay? You would need to differentiate that out. Also, note that this may also have a positive Mulder's test. One little note on Mulder's test. So a long time ago, when I actually started to develop the Morton's neuroma in my right foot, I did not know what it was. It was actually very painful. I thought for a while it was something else, like plantar fasciitis. So it wasn't getting better, and I thought, oh my gosh, do I have another extra bone growing in my foot? Because I had extra bones growing in both feet that I had surgically removed. I was like, oh crap, what is this? And in the past, I got prednisone for it, and that staved off the pain for quite a while. Eventually, it didn't do any good and had to have surgical removal. But it wasn't fun, so I went to urgent care to try to get some prednisone. Well, she seemed to think, that is the doctor, that it was a Morton's neuroma. So she proceeded to take my foot, and this is not really an exaggeration. Let me actually just use a shoe here. Pretend this is a foot. She takes it and she just, like that. Let's just say she's lucky she has a head on her shoulders, because I almost kicked her head off. It was horrible. That was horrible pain. If you are ever conducting Mulder's test and somebody kicks you really hard, you deserve it, okay? Don't ever do that test that hard. What I showed you earlier on about doing it very gently and easing into it and stopping as soon as the pain is reproduced, if it is, that is how the test is correctly done, okay? If you squeeze as hard as I just showed you a second ago, you could have somebody with neither of these conditions and no issues in the foot and ankle at all that will jump out in pain, okay? Don't ever do that. That being said, what do we need to do to treat metatarsalgia and Morton's neuroma? I already said that the treatment approach is very similar. Well, for metatarsalgia, there's really not any good medical approaches for this. I know some people in the past have tried cortisone injections for it. That's not going to work very well. There's not really any good surgeries for it. For Morton's neuroma, they do have a surgical excision of that part of the nerve. Unfortunately, that portion of the nerve can grow back and produce the same pain, potentially. There's also nerve ablations they can do. There's cortisone shots, but a lot of these things are either not very effective or they're only temporary because a nerve can grow back, whether it's cut out surgically or it's ablated. So what do? Well, you should try physical therapy. And the first thing we're going to do is we're going to offload the neuroma, or that portion of the foot that's painful in metatarsalgia. And when I say offload it, I don't mean going in a boot. I don't mean going on crutches and going non-weight bearing on that side. I'm talking about a metatarsal pad. So whether this is metatarsalgia or a Morton's neuroma, it doesn't really matter. Let's suppose that X on the bottom of the foot there, that is the painful spot that we're trying to offload. Next to the foot there, you see a metatarsal pad. Metatarsal pads you can get almost anywhere. They're available in drugstores like Walgreens, CVS. You can get them on Amazon, and I'll be putting a link to purchasing metatarsal pads on Amazon in the comment section of this video. I'll have it pinned, so make sure to check that out. So where do you put the metatarsal pad? Well, here's where not to put it, and that is right on or over the painful spot. This is actually going to increase the force or amplitude of that repetitive stress every time you're walking and you go onto the balls of the foot there. Don't do that, it's going to feel worse. The whole goal of this offloading is to get a very quick, noticeable reduction in pain. Because when you get that reduction in pain, you know that you have to some extent offloaded it. So where do you put it? Well, here's what you do. You notice that the bottom of that metatarsal pad, the way it's pictured, is narrow and the top is wide. We're going to put the wide end of it just proximal to that painful spot on the bottom of the foot, maybe gapping it by like a centimeter, okay? And it's not a one size fits all. You might have to finagle around the position of it to find where it is painful. But once you find the spot, you're golden. Here's actually mine right here. So I've got the insert in my shoe, and hopefully you can see right there that thickened part that I'm tracing. That is the metatarsal pad that I'm using. And then I just put some Gorilla Tape over that so it stays on there very, very well, okay? How do you know that you've got it in the right spot? Well, once you put it on there, maybe with some lighter tape that's not going to be so permanent, you put the insert back in your shoe, you put your shoes back on, you stand up, you take a few steps, and you should notice that that point feels less painful. Does it have to abolish pain altogether? No, and it probably won't unless your pain severity was like a 1 or 2 out of 10. Most people, by the time they get to this point, the pain level is quite a bit elevated. So maybe your pain initially was like a 6 out of 10. If it reduces to like a 4 out of 10, you know it's in the right spot. You want that reduction in pain. If it did get rid of it altogether, great, but it probably won't. It'll probably just reduce it. But if you then, with that spot, put that really strong tape around it to hold it in place so it doesn't shift around, and then you go back to doing your daily activities, you know that you're getting decreased stress on that spot and it will calm down. Now, if the impairments in your foot and ankle were very minimal, if any, this may be all that you require. Just some simple offloading and you're good to go, and over time it will desensitize and eventually probably forget about it. But most of us have some type of impairment that caused this to form in the first place. And over there on the left side of the screen, you can see a variety of potential impairments that can come out in a foot or ankle assessment that can contribute to this repetitive stress on the forefoot and the formation of a neuroma or a metatarsalgia. This is why it's important to be checked out by a qualified physical therapist. What are some of these impairments? Well, we've got limited dorsiflexion range of motion, limited great toe extension, that is the big toe at the MTP joint, its extension is limited. Both of those things will put more stress on the forefoot when you're walking. Other mobility deficits, midfoot mobility, such as talonavicular joint mobility, subtalar mobility, intermetatarsal mobility. I can tell you that my midfoot mobility and intermetatarsal mobility were both restricted when I saw the physical therapist for this. And then strength issues of the foot intrinsics, subtalar inversion, so tibialis posterior, and plantar flexion, so the triceps surae, gastrocnemius, and soleus. So I developed this neuroma roughly a year after getting a bone removed from my right ankle. It was an accessory ossicle called an os trigonum. And as a result of that, my calves were actually pretty weak. And I had tried to strengthen them, and it just takes a long time to get those stronger. And when I developed the neuroma, of course, I stopped doing all that stuff because it was too painful. And so when I went into physical therapy, one of the things they had me do was strengthen the plantar flexors. Heel races, but I couldn't do standing ones, certainly not single leg. I couldn't do double leg. I had to start with seated with no added resistance. And as I was able to tolerate that, we added a little weight on my thigh. You know, do your seated heel races, a little weight on the thigh, right? Once that became more tolerable, I went on the leg press. So I wasn't doing my full body weight, but I started like 20 pound, 30 pound, gradually increased the resistance, but just to the point that I could tolerate it. Part of the job of a physical therapist in rehabbing a neuroma or metatarsalgia is to find the impairments, but to only press them as much as the person can tolerate. Yes, my calves needed to get stronger, no question, but I'm not starting with body weight heel raises. That was way too much. I had to regress it way back down and make little progressions each week until eventually I was able to do a standing heel raise, and we're like, okay, you're good. Now go to the gym and hit the heel raise machine. And then pretty soon I'm back to doing this roughly a year after that. It took a long time, okay? But if you find the impairments, meet the patient where they're at, and then progressively overload, whether it's mobility, whether it's strength, etc., you can fix these impairments that were putting too much stress on the forefoot. And then combined with that offloading with the metatarsal pad, we can allow that neuroma or the metatarsalgia to just desensitize over time. It's not receiving all this stress every single step, and so it calms down. And if it was metatarsalgia, it can completely go away permanently. If you have a neuroma, it'll probably always be there, but we could think of it more as a dormant neuroma. Still got some fibrotic tissue around it, okay? It's not going anywhere, but it's also not screaming at us, and it allows us to do the things that we want to do, and for us to live a happy, pain-free life in the foot and ankle. So hopefully this video gave you a good understanding about how to assess and treat Morton's neuroma and metatarsalgia. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.